Hi, I'm Dr. Gayatree Mohanty. I'm here to present a case of recalcitrant scleritis due to vaginous disease. She was treated with rituximab and then presented to us with increased intraocular pressure. Our case here is a 25-year-old female with recalcitrant scleritis. She is a known case of vaginous disease, which is called granulomatosis with polyangiitis nowadays. Along with joint involvement, a positive C-ANCA, high CRP, and high erythrocytic sedimentation rate. She is being treated with both topical and systemic corticosteroids along with cyclosporins. Her respiratory and renal failure were normal. She had no signs of glaucoma or steroid-induced glaucoma in her past follow-ups. There was no family history of glaucoma. Our rheumatologist then recommended for 3 cycles of rituximab, 1000 mg, 1 month apart, to treat the scleritis. But after the first dose of rituximab, she presented in our clinic with sudden onset of blurred vision and severe pain. On examination, she had a vision of 2200 in both of her eyes and very severe ciliary congestion and corneal edema. The intraocular pressure was measured on Bowman tonometry to be 60 mm mercury in the right eye and 30 mm mercury in the left eye. The anterior chamber appeared quiet and deep, and we could not appreciate the anterior vitreous face and the fundus because of corneal edema. At the time of his episode, she had no form of corticosteroids intake or any other medication that could have raised her IOP. We were lucky to have the intraocular pressure reduced with systemic and topical anti-glaucoma drugs. She responded well, and she was kept on a maintenance dose of combination eye drop, dorzolamide and timolol 0.5% in a twice-a-day dose, and she had no recurrence of scleritis and did not require any systemic or topical corticosteroid thereafter. Her angles were wide on gonioscopy and the fundus was normal, so the optic nerve was all normal. But she presented our clinic again after her second and third cycle of rituximab with similar complaints of blurred vision, cloudy cornea, quiet anterior chamber, but the IOP above 30 mm mercury requiring systemic acetazolamide despite the maintenance dose of topical torzolamide and timolol 0.5%. Her intraocular pressure was measured post the second cycle to be 32 mm mercury and in the left eye 26 mm mercury. Post the third cycle was 30 mm mercury in the right eye and 28 mm mercury in her left eye. Despite the long-standing raised IOP, the optic nerve head and the retinal nerve fiber was healthy on the optical coherence tomography all throughout the follow-ups until now. So with no history of raised intraocular pressure with corticosteroids earlier with the previous episodes of scleritis and a coincidence of rise in intraocular pressure post-rituximab injections, with the diagnosis of exclusion, we diagnosed the patient to have rituximab-induced raised intraocular pressure. So to discuss a little about the scleritis and the rituximab, Scleritis is a very severe ocular inflammatory condition. It could be infectious or non-infectious. It is associated along with this malignancy, along with autoimmune diseases and post-surgical conditions. It is a common presentation along with Wegener's disease. It happens in 7 to 10% of patients, and the most common is diffuse anterior scleritis, and the necrotizing scleritis is the most malignant form of anterior scleritis that happens in Wegener's disease. So there is a high risk of globe perforation and loss of vision in necrotizing scleritis. On examination, the patient might present to you with a red, tender eye with capillary closure and non-perfusion, which results in infarction and thinning of the sclera. It can also extend to the neighboring structures. Rituximab here is an immunomodulator. It is a chimeric murine or human monoclonal antibody against the CD20 antigen on human B cells. It results in depletion of the B cell and the B cell precursors, though the long-lived plasma cells and the stem cells are not affected. The B cell source can be lowered for almost 6 to 12 months or more. It also lowers the level of the circulating IgG and the IgM antibody. Most commonly, it has been used earlier with non-Hodgkin's lymphoma, multiple myeloma, and chronic lymphocytic leukemia. But recent studies have shown that it is non-inferior to cyclophosphamide in the treatment of granulomatosis with polyangiitis, and it has a FDA approval now for treatment of Wegener's disease. It has been found that it also reduces the prednisolone dose in treatment of uveitis and juvenile arthritis. The recommended dose for ocular inflammation in adults is a single dose of 1000 mg infusions 2 weeks apart to result in complete peripheral B cell depletion and disease control with time. But if there is incomplete response or there is any relapse, additional infusions may be tried after a few months. It has been found to be safe in cancer and rheumatoid arthritis, though in minor population you might see increased chance of infection, Stevens-Johnson syndrome, infusion reaction, pulmonary edema, and progressive multifocal leukoencephalopathy. Here are a few literatures that I found showing the ocular adverse effects of rituximab. The one which is most similar to ours is the Halida et al., which is a case report where they gave intravitreal rituximab, not systemic, in vitreoretinal lymphoma. So they found transient uveitis and secondary rise of intraocular pressure, but the symptoms were resolved. The others were case reports and random control studies by Shea, Sullers, Ahmad, and Mariella for granulomatosis with polyangiitis. There was systemic infection of rituximab. There was no systemic adverse effect, but Shea saw exacerbation of ocular inflammation. Sullers had exacerbation of ocular inflammation. And in Ahmad RCT, there was reactivation of scleritis in few patients. In Suller and Ahmad study, the disease resolved, but the case report of Shea, there was exacerbation of symptoms along with exacerbation of ocular inflammation. The case report of Mariley of non-Hodgkin's lymphoma where systemic rituximab was given. They had conjunctivitis and resolution of disease. All these did not show any increase in intraocular pressure apart from HASIDA. In contrary to other studies, our patient had complete resolution of refractory scleritis. There was no ocular inflammation at all post rituximab glaucoma, but we have increased intraocular pressure. So she remained to be having ocular hypertension post rituximab. Her optic nerve is all normal, so we do not have any glaucomatous optic neuropathy so far, but she has to be maintained on dorzolamide and timolol. To conclude, the IOP can rise with systemic rituximab like intravitreal rituximab. So the awareness of the ocular toxicity profile is crucial to reduce the treatment-related ocular morbidity. My take-home message would be rituximab is a promising drug, but the use requires caution. The side effects require further investigation. Here are my references, and thank you so much for your patient hearing. Have a good day.